Yes, I've been in the medical field for 37 years. The last 30, I've been practicing in the emergency room, but I'm also a nurse in a pregnancy crisis center, and I am blessed to do the ultrasound, so I'm a window into the womb. So today I'll be talking about two different topics concerning the beginning of life, both originating outside of the womb. In July the 25th of 1978, Louise Brown was born in Manchester, England, and the world was watching. What was so special about this baby girl? With the medical and scientific expertise of Drs. Steptoe and Edwards, her mom, Leslie, underwent an experimental IVF procedure that removed mature eggs from her ovary and combined them with her husband's sperm in a petri dish within a lab to form an embryo. The dot-sized embryo was then transferred and transplanted into the mother's uterus, and 9 months later, little Louise was the world's first test tube baby. Indeed, it was a miracle of science, but at the same time, a recipe for many a moral and ethical dilemma. At the outset, there were many concerns regarding the new and uncertain technology. Let's fast forward to 2017. IVF births no longer make the headlines, for after 4 million, it is old news. What hasn't changed, though, or gone away, is the aftermath and reality of those first moral and ethical questions. Because a certain procedure is technologically possible, does it necessarily follow that it is ethically right? Travel with me to the Reproductive Center in San Ramon, California. The Christian news magazine World wrote an informative article about this center. With its sleek and mirrored walls, there are now row after row of closely monitored tanks filled with liquid nitrogen. Each tank holds cylinders that have straw-like structures carefully placed within. Levels and temperatures set to alarms are carefully observed by technician. In each of these straws within the cylinders, there is 5 embryos. This particular facility has more than 15,000, a small fraction of the growing multitude, now estimated in the millions, of human life suspended in its earliest form. Usually, 1 to 3 eggs are implanted in the mother-to-be. The extra embryos are frozen, and in the process of egg retrieval, there is an average of 10 extra eggs that are removed and fertilized. And this is where the questions begin. Do these cell clusters represent life? And what to do with the remaining embryos that are frozen in time? Couples contract with facilities such as the one in California to store their extra embryos, and they pay $45 a month for up to 5 years, and after that, the rate increases. And this is a way to encourage the parents to move to long-term storage or to look at their other options. What are those options? They include donation to medical research, or to give an embryo up for adoption to an adoption center, such as Nightlife Christian Adoptions, their Snowflake program. But lastly, the option is to destroy them by thawing and dispensing of them into biohazard waste bins. The question we are asking today is, how can we change the way we do this? We can feel the angst of parents waiting for a baby and their joy at welcoming their child into the world. In the beginning, this is their only thought, but now they are facing the anguish of having to decide what to do with the extra embryos that they've helped create, embryos that are a real part of them. One question we can ask, does there have to be so many eggs retrieved? We understand the reasoning is that should these parents decide to have more children, this eliminates the financial and physical strains of undergoing multiple treatment cycles. So does convenience and comfort trump the moral and ethical concern surrounding the multiple egg retrieval practice? Many parents are haunted by the consequences of not answering this question. Reproductive centers state that marital tension is very common. Mothers most often wish to keep the eggs and think of them every day, according to their testimonies, while fathers often just wish to ignore the problem and not be bothered with them. A frequent situation then, as in the testimony of the San Ramon Reproductive Center, is that the embryos are abandoned. The employees, the technicians, find it really, really difficult to dispose or destroy the embryos. In fact, the reproductive center in California that I've been speaking about has never thrown or has never thawed and disposed of a single embryo that has been abandoned. They have embryos in their tanks that have been there for 26 years. In all of my research, I find this information to be extremely thought-provoking. Such behavior strongly suggests that they understand, even from a scientific point of view, that life begins when sperm cells join with egg cells, regardless of if that event occurred in a lab. If we believe that the zygote is human life with potential rather than potential human life, what will we do differently? How will we address the moral and ethical questions that still remain 4 million IVF births later? How can all branches of study, science, medicine, law, history, ethics, and religion tackle the complex dilemma of in vitro fertilization? These questions that just don't go away. They include the beginning of life, the embryo created outside of the womb, many embryos or future children frozen with uncertain fates, donation to science or the sacrificing of their lives, turning children into commodities, gender choice, stamping out defects to create the perfect child. Being pro-life is about so much more than being just against abortion. Humans are made in the image of God, and we need to let the truth that all life is sacred seek in. Perhaps change will only happen when we begin to think differently, when our attitudes and priorities and motivations shift exponentially. We need to ask, what are the alternatives to IVF? There's hormonal therapy, fertility drug treatment, but the one most after God's own heart, in my opinion, is defending the cause of orphans. James says, pure and undefiled religion before God is this, to care for orphans in their distress. What would need to change for a couple to consider this option over in vitro fertilization? And what can we do differently to encourage and promote adoption? This can mean even the adoption of frozen embryos. Instead of creating more, rescue one suspended in the liquid nitrogen with an unknown future. We have been discussing science and medicine creating life outside the womb, and now we're going to shift to an aberrancy of nature itself and a pathological or disease condition known as ectopic pregnancy. The word ectopic is a Latin term from a Greek word meaning out of place. An egg of a woman is fertilized and then travels and implants itself outside of the womb. Though both conditions I am speaking on in word have the same definition, the similarity ends there. They are vastly different, but the same moral and ethical challenges surround them. The most common implantation occurs within a fallopian tube, hence the term tubal pregnancy. Much rarer are pregnancies that develop in an ovary, cervix, or the abdomen. The occurrence of ectopic pregnancies has increased significantly due to the rise of STDs, or sexually transmitted diseases, fertility treatment, smoking, stress, and drug use. Although the frequency has increased, the treatment options are unchanged. Statistically, there are 6.6 ectopic pregnancies per 1,000 births in the 15 to 24-year-old age group, increasing to 21.5 per 1,000 pregnancies in the 35 to 44-year-old age group. This equals about 200,000 such pregnancies a year in the United States. About 40 deaths a year occur due to a ruptured ectopic pregnancy in this country. Thankfully, better diagnostic tools enable early detection, diagnosis, and intervention, decreasing the risk it poses. I need to clarify that an ectopic pregnancy is a disease condition and considered a true medical emergency. It is often referred to as a ticking time bomb. When the ectopic ovum or egg begins to develop in the fallopian tube, the placental villi erode the tubal wall and the blood vessels. If a woman is diagnosed with an ectopic pregnancy, non-treatment is medically unacceptable due to the risk of ovarian artery rupture, leading to massive pelvic bleeding. No tubal pregnancy goes beyond the first trimester or the 13 weeks. It either dies and a spontaneous abortion occurs, it bursts and an emergency surgery is performed to remove the damaged tube, or a surgery is proactively done to remove the pregnancy before irreversible damage to the fallopian tube occurs. We have discussed some of the great strides modern medicine has made in the area of reproduction. Yet one opens a textbook of medicine, reads any journal or an e-paper, and discovers this statement over and over again: no medical technology exists to move an ectopic pregnancy from a fallopian tube to the uterus, unquote. I am sure you are as incredulous as I am that no surgical solution has been found to transplant an embryo from a tube to the uterus. They harvest eggs, gather sperm, fertilize in a petri dish in a lab, transplant, implant, cell clusters into the uterus, yet no one has found a way to surgically remove an ectopically implanted embryo from a fallopian tube and transplant it to the uterus. It is a sad and very difficult position to be in as a nurse or a doctor, to have to tell expectant parents that their pregnancy that they have been so looking forward to is a life-threatening condition to both the mom and the baby. For a fallopian tube cannot accommodate a growing fetus. It can never reach a viable age, survive, and be born. So is there something we can do differently? Earlier, I list some of the factors, risk factors of ectopic pregnancy. So women need to be educated to look at those habits in their life that may predispose them to ectopic pregnancies. But truth be told, it can happen to anyone. And I wish I could say that there is an easy solution, but at this point in time, there is not. A woman is left with 3 options: surgery, which means the removal of the tube with the embryo, or create a surgical hole into the tube to remove the embryo and save the tube, but either way, the embryo dies. There's methotrexate, which is a pharmacological agent that inhibits cellular reproduction. It is a chemo agent that kills the growing embryo. Or just leave it be. Do not intervene at all. But this risks potential hemorrhage and death of both mom and baby. And now you ask, why is the treatment for ectopic pregnancy not considered to be an abortion? The reason lies in the intent. The treatment of the ectopic pregnancy, the physician's intent is a treatment of an abnormal or disease condition and averting serious or life-threatening risks. The intent is to save a life, not destroy a life, although the embryo does die. Remember, with abortion, the intent of the physician is to end the life of a living and viable baby. Treating a woman with an ectopic pregnancy has never fallen into the abortion category, not since it was first discovered hundreds of years ago. I can tell you that there are Catholic hospitals that refuse to treat women with this diagnosis. They monitor the woman's HCG levels and pray that she aborts spontaneously, or they tell her to seek medical attention at another hospital. While we all agree that protecting the lives of the unborn is of utmost importance, the duty of doing no harm is seriously being ignored in this scenario. Not only is the mother's life needlessly being put at risk, but remember that the baby is not viable in a fallopian tube. Additionally, the consequence of a burst tube is that it will need to be removed, thus reducing her chance at another pregnancy by 50%. So one must ask, where are the scientists, the doctors, with imagination, ingenuity, and the passion to persist and endure until a heroic solution is found for the treatment of ectopic pregnancy? Perhaps what we can do differently is do our jobs better in proclaiming that life begins at the moment of conception. If physicians and scientists believed that the embryo is a human being with potential, it would propel them to successfully find a way to transplant it from the tube to the uterus. We know that routine heart, lung, and liver transplants become routine only after many failed attempts. So I hope that one day the long night of the dying embryo will end, because a brave man or woman will rise up and take the cause of finding a way to transplant them from the place outside to a place within the safety of a mother's womb, and that this procedure will be as safe and routine as the IVF procedure has become. Until then, the emergent treatment of an ectopic pregnancy will remain a heartbreaking one. Are we convinced of the relevance of our mission? Until we are, our efforts will be mediocre at best. Do our hearts burn with purpose and passion? It is the only way we will inspire those around us to join the battle against the unjust violence being perpetrated against the unborn. And may the sanctity of life drive us to our knees and then become what we stand and work for. And may each of us become so pregnant with the passion for life, having such a profound vision to change the landscape of the unborn, that birth is given to a future where embryos are embraced as human, whether from a petri dish or a fallopian tube, counted as valuable and precious, deserving of their first breath.